All right. Excellent. I guess we can go ahead and start, Peter, and then people are going to be trickling in as we go on, so we can just go ahead. So we have Dr. Peter Fiester. He's a associate professor of neuroradiology at University of Florida in Jacksonville, and today we're going to be talking about imaging anatomy and traumatic injury of the craniocervical junction. And with that being said, we'll let Peter take it from there.
Yeah, thank you, Dr. Rasuli, virtual spine faculty, for having me. It's an honor to be here. So I'm going to talk about anatomy and traumatic injury of the craniocervical junction. And the craniocervical junction is kind of a niche interest of mine. And it's interesting for those who don't know, but neuroradiology is kind of subdivided arbitrarily into brain imaging, spine imaging, and head and neck imaging. And if you think about it, the craniocervical junction is kind of at the intersection anatomically of those three areas. So I think sometimes it gets a little bit overlooked by the neuroradiology community, and that's why I kind of took an interest in it. So today I'm going to be talking about kind of this idea of craniocervical dissociation spectrum injury from a neuroradiology perspective. And then we'll be talking about a little bit about the osteoligamentous anatomy, and then the cross-sectional anatomy on CT and MRI. And then I have 8 trauma cases of craniocervical junction trauma. And again, I built in a lot of time to have kind of an open discussion. I'd love to get surgical feedback, your interpretation of the imaging, and kind of your management thought processes. So points to consider before I get started. I always tell all my residents that when you think about the cervical spine is really 2 spines in one. You have the craniocervical spine and the subaxial spine, right? And they differ in embryologic development. They have different anatomy. They have different function. They work biomechanically much different, and the traumatic injuries that occur are very different. And the reason, of course, is that the craniocervical junction has the added burden of not only maintaining the maximal amount of stability, but it has to have the greatest possible range of motion. And it's interesting that, during my training, I've been out of residency for 5 years, but, we've noticed this increasing utilization and availability of cervical MRI for trauma patients. And that's kind of starting to change our radiologic perceptions of craniocervical junction trauma. And what I mean by that is that when you think about craniocervical junction trauma, for me, I best, think about in terms of it being a spectrum of injury severity. And that's determined by the age of the patient, their bone density, their underlying ligamentous integrity, and then the increasing hyperflexion, hyperextension, traumatic forces applied. So when you think about that way, you can kind of have it as the spectrum of trauma, where the most severe, most significant injuries are going to be those in which you have major craniocervical junction ligament tears, and then you get overt aleno-occipital dislocation. It's basically aleno-occipital dissociation injury, AOD. If you think about then the least severe kind of spectrum injury, those would just be your isolated kind of ligament tears, the craniocervical junction. And the one that comes to mind is like an alar ligament avulsion or an occipital condylar avulsion injury. And then between those two extremes, you have all these various patterns and different imaging presentations of osteoligamentous trauma. And those can produce a low, an intermediate, or high probability of craniocervical instability. So that's kind of the area of research that I'm interested in. I think as we kind of understand that more, that we'll be able to tailor management to patients on a little bit more imaging case-by-case basis. So any talk on the craniocervical junction, you have to begin with anatomy. And Dr. Baj, you said it on Twitter a few weeks ago, where you said the craniocervical junction is some bone, but mostly ligaments. And that was like the most accurate description of the craniocervical junction I've ever heard. It's very true. And I agree with you 100%. So you have to really know these ligaments. So for simplicity's sake, if you just start anterior and kind of work your way posterior, this is of course a midline sagittal illustration. The first ligament you have is the anterior membrane complex. And the anterior membrane complex is actually 2 named ligaments. There's the aleno-occipital membrane, which runs from the clivus, the anterior tubercle of C1. And then you have your aleno-axial membrane, which runs from the anterior tubercle of C1 all the way down to the C2-3 disc space, and then continues, of course, as the anterior longitudinal ligament. So biomechanically, what does this ligament do? Well, this is probably a minor stabilizing structure of the craniocervical junction. it probably helps some degree as well of passive, allowing passive stability and prevents anterior translation of the arch in relation to the dens. As you move posterior, then the next ligament you run into is this apical ligament. And the apical ligament is an interesting ligament. It's actually not really a ligament. Cadaveric evaluations of this ligament have shown that it's actually notochordal tissue. It has a notochordal tissue core, and it's surrounded by elastic fibers. And it's basically vestigial notochordal tissue between C0 and C1. And this ligament probably contributes almost nothing to craniocervical stability, but it is a named ligament, and you can see it very well because this supradental space is filled with fat. So this ligament stands out very nicely on imaging. As you move more posterior, then you get into the superior band of the cruciform ligament, which runs from the basion and goes inferiorly to the mid-transverse alanal ligament and forms a superior extension of the cruciform ligament complex. This ligament, again, is probably a minor stabilizing structure. You don't generally see it separate from the tectoral membrane, which is just posterior to it, and probably not the most important ligament in terms of stability. And then we get into one of the major stabilizers, in my opinion, and I think a lot of prior research has kind of shown this as well, is the tectoral membrane, which is highlighted here in teal. The tectoral membrane is an interesting ligament because it actually interdigitates directly with retroclipable dura. And cadaveric studies have shown that it actually inserts all the way up to the dorsum sella, where you have elastic fibers which are still intermingling with dura all the way that high up. And it's firmly adherent to the clivus. And then as you go down, it forms kind of a sling where it's loosely attached to structures along the dens and then becomes firmly adherent of impingement of the dens on the cervical core with hyperflexion or flexion of your neck. And it also probably provides some degree of tensile, prevention of dissociation between the skull base and C1-2. And then lastly, you have your posterior membrane complex. Your posterior membrane complex, just like your anterior complex, has two named components. The one that runs between the occiput and the posterior arch of C1 is the alano-occipital membrane. And then below that, from the posterior arch of C1 to the lamina of C2, you have your posterior alano-axial membrane. And then, of course, that continues inferiorly in the subaxial spine as your ligamentum flavum. And this is an interesting ligament as well. It rises from fascial coverings of the rectus posterior major and minor muscles, which sit in the suboccipital compartment, and also rises from the sheaths that are surrounding the vertebral arteries. And it forms a myoligamentous bridge to the dura. It actually inserts directly on the posterior dura at C1-2. And it's a ligament that's of interest in patients who have cervicogenic headache for that reason. Sometimes it's studied in that context. And then just for completeness sake, so get another view of these ligaments on coronal, the tectoral membrane again here, inserts very high up along the dorsum aspect of the clivus, interdigitates with the dura directly and forms a sling, and then continues down as the posterior longitudinal ligament. If you cut that ligament away, then we get a good shot of another major stabilizing ligament. These are your alar ligaments, and your alar ligaments attach at your occipital condyle to the tip of the dens bilaterally. And then you also get a nice shot of the cruciform ligamentous complex. You have the superior band here again, which is a minor stabilizer. You have your transverse alanal ligament, which we'll talk about in a second, and then you have your inferior band. And then if you look at it on a posterior approach, on a coronal point of view, this is the posterior membrane complex, the alano-occipital component, which is actually pretty wide, and the posterior alano-axial component between C1 and C2. Then finally, so the major stabilizing structure of the alano-axial joint, so the transverse alanal ligament. The transverse alanal ligament runs from the medial tubercle C1 to the medial tubercle C1. Not a lot, but I've read that, a lot of people consider this the functionally most important ligament in the body. And I think you can make a case that's probably true. It has two functions to it. One is that it allows rotation of C1 on C2. And the way it does that, it has a little capsule, synovial capsule anterior to it. And the anterior margin of the transverse alanal ligament has a smooth fibrocartilaginous surface, which facilitates rotation of the atlas on the axis. So that's function number one. Function number two, of course, is that it's going to prevent anterior translation of C1 in relation to the dens. So it's a very important ligament, easily seen ligament on MRI. So just, that was a lot of the anatomy. So the major stabilizing structures, the alano-occipital joints and the capsular ligaments, which we'll talk about in a second with CT imaging, your alar ligaments, your tectoral membrane, those are the major stabilizing structures of the craniocervical junction. And then your transverse alano ligament, of course, is your major stabilizing structure of your alano-axial joint. And then really all the rest of the ligaments we talked about are kind of considered minor stabilizing structures, the anterior and posterior membrane complexes, your vestigial notochordal apical ligament, the superior band, and then the neurosurgeon, Dr. Tubbs, did a lot of cadaveric work and delineated all these accessory ligaments that we have that we don't routinely see on cervical MRI, but just so you know, there are additional accessory ligaments. So how do we take that anatomy and then try to apply it to our patients, apply it to our imaging? Well, we can apply it in terms of CT evaluation and then MRI evaluation. So we start by CT evaluation. This is a good coronal CT, and I prefer a coronal CT to look at craniocervical junction anatomy. Just lays out the joint spaces and anatomic spaces really nicely. So I want to draw your attention to two specific joint spaces. So one is the alano-occipital joint, which is delineated obviously here by the red arrows. It's a smooth articular surface. The condyle has kind of a convex surface, and the lateral mass of C1 is kind of a convex surface. So it kind of fits right in there like a cup. And they've done studies in normal patients and normal people, and this joint space should really never be more than 2 millimeters in a normal adult individual. So that's one important relationship. Another one is going to be the lateral mass offset, which is designated here by the blue arrow. There should be nice congruency between the lateral mass of C1 and the body of C2, and any overhang greater than 1 millimeter or so in an adult is highly suspicious for either a C1 burst fracture or maybe a transverse alano ligament tear. And then just for completeness sake, this white line is designating the lateral alano-dens interval. The lateral alano-dens interval, the space between the dens and C1, this space can be fairly strikingly asymmetric in a normal individual. And that's just because with any degree of physiologic rotation of C1 and C2, there's going to be some asymmetry in this relationship. And just for completeness, the lateral alano-axial joint is designated in green. So again,
Peter,
yeah.
Hi, sorry to interrupt. Just a quick question on that last image. And I guess this is a question for you and for Jonathan and anybody else who wants to chime in, either on the in the chat box or if any of the co-hosts want to chime in person. But I was going to refer to what you said at the end here, which is occasionally we'll get somebody who has a trauma and everything is quote unquote negative, but then you look at the CAT scan, you look at the coronal, and you see that asymmetry. You see the dens, towards one side, one lateral mass more than the other. It's tough to tell whether, were they born like that? Is this a chronic, non-pathologic asymmetry, or is it really something to worry about? And I know everybody, is going to have a different algorithm on how to treat those, but what are your thoughts on? Do you guys have anything in your literature on the the incidence of that, or the prevalence, actually the prevalence of asymmetry? And then back to, I guess, Jonathan. What do you think, Jonathan, in terms of what do you see when you see a post a trauma patient with that asymmetry, but there's no subluxation, the ADI is fine, it's just a mild asymmetry of the dens in relation to the lateral masses? So would love each of your thoughts on that.
Yeah, I can. So there was one study that measured this relationship in normal individuals, and it can be really asymmetric. And I don't remember the exact number. The asymmetry is okay as long as there's no lateral mass offset, the lateral mass hanging off here. If there's asymmetry and some overhang of the lateral mass of C1, in my mind, that makes me worry that there's some pathologic translation or pathologic rotation occurring. But it can be very asymmetric and does draw your attention. So it is a bit of a problem. And sometimes you have to do an MRI to kind of tease it out from my end.
Yeah, 100% agree. That's exactly what I was going to say. I look for overhang of the C1 lateral mass relative to C2. The asymmetry is pretty common. Other things you can look for is maybe a little avulsion fragments of the medial aspect of the lateral mass. If you see that, that can also clue in there's injury to the transverse ligament. But I think ultimately, if you see some sort of asymmetry in a trauma patient like that who's having significant neck pain and or neurologic deficit, I think you're kind of committed to getting an MRI anyway, so you can get a better evaluation of that. I think the more important thing is just if there's evidence of ligamentous injury posteriorly, and or a widened ADI on sagittal.
Yeah, so speaking of ADI, so the sagittal CT evaluation, that's probably your most important relationship. And of course, that should be less than a few millimeters in most adults. You know, there's all these lines, and sometimes you hear neuroradiologists reference these lines. These lines are really a hangover from the days of plain film. So don't put too much stock into, you know, there's a radiologist who's commenting on these lines. And, you know, these lines can be abnormal in developmental, non-trauma patients, and they can be normal in patients with significant trauma. And then, yeah, Jonathan, just like you're alluding to, so this is the medial tubercle C1, and this little piece of bone can avulse. This is right where the transverse alanal ligament inserts. So that's definitely one thing you're going to look for on CT. And then obviously the alar ligament, which can avulse the condyle as well, is another potential finding for craniocervical trauma on CT. So cervical MRI is awesome. I love cervical MRI. I wish we did it more for craniocervical trauma at my hospital. You can see these ligaments, especially in younger patients, so nicely. These are T2 weighted images, and you know, a ligament on a T2 weighted image is going to be nice and black all the way down. So this is your anterior lano-occipital. This is your anterior lano-axial membrane. This is that little notochordal apical ligament. You actually get a nice little shot of the superior band of the cruciform ligament. You have your tectoral membrane, the subclavial component here, which you can see really nicely. And then the posterior lano-occipital and posterior lano-axial membrane. And then, you know, I love looking at the alar ligament on a sagittal. You can see the ligament coming up and inserting on the condyle really nicely on both sides. And then, of course, our longus capitis muscle, which is the muscle anterior to all these ligaments, and then the posterior membrane complex. And then our transverse alanal ligament, which again, nice dark structure on a T2 weighted image, nice normal looking transverse alanal ligament. This is another T2 weighted sequence showing that it's intact. So I sometimes get asked by residents and sometimes surgeons, how do you know the ligament's torn? You have to fulfill both of these criteria. There has to be a discontinuous or disrupted ligament on T2 weighted imaging. There's a gap in the ligament. And then you also have to have increased T2 or stir signal in the ligament. So if you fulfill those two criteria, you have a torn ligament. So this is, for comparison, a nice normal transverse alanal ligament. And then this is obviously a torn ligament, and the image quality is not great, but you can see there's a gap in this ligament. There's increased T2 signal in the ligament. So that's a tear of the right transverse alanal ligament on MRI. And that's what you look for, those two criteria. So that kind of concludes our anatomy part. So I'd like to, you know, obviously have a nice open discussion now. I've got 8 trauma cases to go through.
Peter,
yeah.
Sorry, another follow-up question before we get to the cases. Thank you so much for that initial presentation. That was a really nice review. Again, back to the neuroradiology aspect of assessing the ligaments, where you've nicely laid out what it means to have a torn ligament. You know, for us in surgery, we typically, you know, the dogma as well, ligaments don't heal as well as bones, right? But have you been involved in work, or have you seen follow-up MRIs on torn or injured ligaments that radiographically and you know, say using MRI, you've actually seen healing? And what does that look like? Is the ligament back to how it would otherwise look, or does it form scar in the area? How does a healed ligament look on MRI after it was torn, I guess?
Yeah, that's a fantastic question. You know, that needs to be studied. To my knowledge, that really hasn't been studied. And you think that would have been studied? You know, just anecdotally, I've seen ligaments that are clearly torn. You know, you get externally braced or supported, and the ligament never really goes back to normal imaging wise. It becomes like kind of a more dark amorphous signal. Fills in that area. I suspect there's some kind of granulation tissue or maybe some kind of mild ligamentous healing that occurs, but I'm not sure. It's never really returned to how it looks pre-trauma, but that hasn't been studied as far as I'm aware. All right, so we got to start off with a bang. So this is a motor vehicle accident. So if you look midline on the sagittal CT, you could argue there's maybe a little bit of mild distraction here. It doesn't really knock your socks off between the basion and the dens. But as you move off parasagittal, I mean, you clearly have, a lano-occipital joint space is greater than 2 millimeters. They're anteriorly subluxed. So just by CT criteria, I mean, this is consistent with the most severe kind of trauma you can have, lano-occipital dissociation. And then this patient got an MRI, and then this is the appearance of all these ligaments. So you just saw a normal picture. This is the abnormal appearance where you have the tectoral membrane is ruptured right here along its subclavial component. Transverse alano ligament is at least partially torn. The anterior complex is torn. There's edema in your posterior membrane complex. And then as you move off midline, this is the alar ligament. This alar ligament never comes up to the condyle here. So this has been torn off the condyle. And then the one on the left side or on the other side has been at least partially torn off the condyle. And then the transverse alano ligament is hanging on by a thread. There's a high-grade tear on both sides, right, grade, and the left, and there's edema all around the ligament. So this is a craniocervical AOD injury with alanoaxial instability. And this is, for radiologists, this is the severe end of the spectrum for craniocervical trauma. So interested to get your guys' opinions, what you think.
Yeah, this is how old is this patient, if you want me asking?
It's like an adult. It's a young adult.
Yeah. So yeah, this is the type of patient that unfortunately tends to come in on Friday night at midnight or Saturday. This is one of those cases that we always dread, other than those like a rigid spine fracture over the weekend. These are tough. You see there's gross instability. It's very, very obvious on the CAT scan, and you're just confirming it with the MRI. So you can see that there's a pretty significant ligamentous injury at C1-2 and C2-3. This is all pretty much pure distraction type injury. In these kind of cases, there's really not much room for medical management, because it just is the nature of this type of injury is that it's so unstable. What makes these cases, really the surgery itself is really an occipital cervical fusion, but or external bracing in select patients, but meaning a halo. But what makes these particular situations so unique and so important that these patients are in a trauma center is just that sequence of events to safely stabilize that patient's head in the stretcher and get them the imaging, get them to the OR, position them. These are all such key things, and can be extremely difficult, especially if the patient has multiple traumas in other areas that are potentially life-threatening. Because this is not, although this is is very dangerous to his neuroaxis, it's not immediately life-threatening. If he has let's say some other abdominal injury or something that's very, very dangerous, that this can all complicate things. So yeah, Ali, I'm just wondering what you're thinking.
Yeah, Peter, thanks for the case. If you go back to the CAT scan, one thing that comes to mind, when we see a lot of these trauma and really look at this, a couple things come to mind. So, you were talking, Peter, about all the ligaments. I think for me, AOD or basically atlanto-occipital dislocation is not very common, right? It's rare. In fact, it's rare to have true clinical instability at the OC junction, right? And if I had just seen that sagittal, right? If I didn't see the parasagittal, if I just saw this sagittal, a trauma patient, I would obviously measure the, I like that measurement. I like the tip of the dens, all the way down, all the way up to the bottom of the clivus. And if it's more than 10 millimeters for me, if it's more than a centimeter, right, then I get worried. But I will say this to me looks a little bit probably, longer than that. Mm-hmm. But if I look at the parasagittals and I didn't see those, and I saw perfect alignment of the condyles on the lateral masses, I probably wouldn't make too much out of it, honestly. So for me, it's like in order to really consider instability of the OC junction, I probably have to see 2 or 3 things, or maybe 4 things, not just one thing, right? But yes, I think clearly here, I think you're going to have a, obviously, even if you didn't get the MRI yet, you're going to have that torn ligament, alar ligament. The capsular ligaments are disrupted. You can tell that because, the condyle shouldn't be displaced like that.
Yeah.
And I agree with with Dr. Rasuli. That's a pretty straightforward case. It's a pretty straightforward OC fusion. There's really not much to consider there. I would say if a patient is medically unfit, or let's say they have polytrauma, just very sick and are not safe to go to the OR, you can consider putting them in a halo, but just ensuring not to further distract them, because in a halo you can distract somebody. So you need to actually compress and get a lateral X-ray. But that's an OC fusion. Sorry for the long answer.
No, that's great. Yeah, that's a great discussion. Yeah, so this is also what scares the neuroradiologist in the middle of the night as well. And it's interesting. So that's a severe case, obviously. This case is another case which is a little bit alarming, because I've seen this maybe a half a dozen times. And this is a case where, like you were just discussing, Ali, that you look at the Bayesian-Denz interval, the distance from here to here, it should be less than 1 centimeter. This one probably measures about 1 centimeter, but then you look on right and left, and the atlanto-occipital joints look pretty good. This one's about 2 millimeters. This one's about 2 millimeters, maybe a little asymmetric, but nothing that really knocks your socks off. But this was a high-speed MVA and another young adult. And lo and behold, they get a cervical MRI and they've got significant ligamentous trauma. And it's alarming sometimes to look at the CT and then to pull up the MRI and see that, gosh, well, they ripped off their tectoral membrane, their transversal ligaments torn, they've got all these accessory minor ligament tears. And I'll tell you that this patient actually had, I believe, a unilateral alar ligament tear as well. So I want to say this patient ended up getting fused as well, but I included this case just because the CT is so underwhelming. And I've seen this a few times, and it's always alarming to me. Pull up an MRI and see that after having kind of a normal looking CT. So I consider this.
That's actually a really awesome case. Can you go back to that CT or MRI, please, Peter?
Yeah.
See what Jonathan thinks. And we obviously have several surgeons with us online here, so please feel free to type in your answers. But this really brings up a very important issue for us as surgeons, right? Because I think if many of us look at this CAT scan and clinically the patient's okay, we may or may not offer surgery, right? Then you see that MRI and there's that added information of torn ligaments, and the neuroradiology report is very scary because everything is disrupted and torn.
Yeah.
And this is where I it's a personal feeling, just a personal disclaimer. I think MRIs a lot of times would push surgeons towards operating, because they're going to pick up things that CAT scans aren't.
Yeah.
It's not necessarily always right or not, but the data is the data. What you see is what you see. So Jonathan, what do you think? If you saw the CAT scan, what would you do? Now the ER, behind your back gets the MRI. Now what do you do? And what do you tell the patients? This is a really tough case, I think.
Yeah, I totally agree. I was thinking the exact same thing. The MRI report's going to be horrible. The CT's underwhelming. Oh yeah, it looks good. And the MRI report's going to look horrible. So, I don't want to overestimate the power of an upright AP lateral X-ray of the patient in a rigid collar and just see what that looks like. If the patient's having tremendous amount of neck pain, and it is clinically appears to have significant ligamentous injury, then I think you're kind of committed to doing something, and I'll give that with a caveat. But I would probably want to get an upright X-ray on this patient with him in a rigid collar to see what the alignment looks like, see how the patient's doing clinically, and you can also just do this an exam under anesthesia. Just bring the patient to the OR, kind of just get a fluoroscopy in there. And just see what things look like. Just do very, very light manual traction to see how unstable he is with live fluoro. And if he looks grossly unstable, then the next step would probably be to instrument infuse him.
Yeah, that's a great discussion. And just I have 2 companion cases. So this was another case
real
Yep.
quick before you, if I can
Go ahead.
pipe up real quick. Sorry, Matt Goodwin, WashU. I'm just curious, Ollie, for that case, because man, that's a great case. That CT is so underwhelming, and we see this, right? Then you get the MRI, and you go, what am I doing? Would you do an examiner anesthesia for this, or how do you treat these?
Yeah, Matt, I'm sorry, was that question for me?
Yeah, I'm just curious. I think we heard.
Yeah, great question. So listen, I've spent, for better or for worse, I've spent a lot of time doing spine trauma back in the day, probably a little bit more than I do now. But I think I really, my personal opinion is there is something called, anatomically or radiographically unstable, and there's something called clinically surgically unstable. And sometimes they overlap, sometimes they don't, right? And we know that from the burst fractures. Clinically, radiographically could be unstable if there's middle column, but for us, they're fine. I think this is a case in which if I saw the CT and the patient's intact, 100% collar, no MRI. Okay. If I'm concerned about a trauma and an increased, Bayesian to dense interval, if the patient has a lot of neck pain and then that MRI is obtained, okay, if you get that MRI, then I would probably keep a little closer eye on him. Collar, upright AP lateral, maybe a short follow-up. But I will tell you this, and this is being recorded, so I'll go on the record. If I saw that MRI, I would still not operate because I think he has neuroradiographic findings that I don't necessarily feel will translate into a clinical instability. A lot of us have seen this. When there's malalignment, and I really believe strongly in those capsular ligaments and how the condyles sit on the CAT scan. If you want to be a little conservative and maybe the patient's in the hospital for a day or two, you can repeat the CAT scan. But for me, alignment is just so much more important than the integrity of ligaments on imaging. That's just a personal bias.
Yeah, perfect.
Yeah, and that plays out with the radiology literature. There's so much controversy of which ligaments contribute to which degree of stability. And I agree, the capsular ligaments are a huge part of the stability here. And, you have to suggest that the capsular ligament is intact, given that there's no widening. I have two companion cases. So this was another case. So just so you can get a good look at the ilano-occipital joints bilaterally, patient gets a follow-up cervical MRI. And again, we have all these ligament tears. And the transverse ilano ligaments torn here, TM is torn, the anterior membrane's torn, and another case where this patient actually had a C1 fracture, has a little bit of subluxation on one side, and then again, this is even a more scary injury where they've got tectoral membrane tears and posterior complex tears and anterior complex tears, and like I said, we had a half a dozen of these cases where it's just very underwhelming on CT, and the MRI just shows all these ligament tears. So I think it feeds into that prior discussion about the difference between the radiology findings and sometimes the clinical and CT findings. So this was a 9-year-old motor vehicle accident, and this was a cervical CT that was done in the middle of the night here. And, you look at this, you're like, oh, there's not too much going on. And then you notice that there's a little hematoma here behind the clivus. So the patient has a retroclipable hematoma. So they got a follow-up cervical MRI. And it shows that, as we talked about with the tectoral membrane, this is the tectoral membrane, this dark line. It's actually been stripped off of the posterior clivus. Remember that the tectoral membrane attaches to the retroclipable dura all the way up to the dorsum sella. And when it gets stripped off in kids, you tear the venous plexus down here, your basilar venous plexus, and you get to a retroclipable venous epidural hematoma. And you can see that this is the venous epidural hematoma on the axial T2. So this is a case of a retroclipable venous epidural hematoma from a tectoral membrane stripping injury. You know it's epidural in location because it's anterior to the tectoral membrane. We did a study on these patients, and we have a bunch of cases, and this is again the tectoral membrane being stripped off. Half of the patients had major craniocervical ligaments, like down here you can see that they have additional craniocervical ligament tears, and the other half had this as an isolated finding. But the hematoma never got bigger in size, and I think most patients were treated conservatively and did okay. And this was another case. So the key is to recognize this on a CT exam. And if you see a hematoma on this compartment in a child, you need to do a follow-up cervical MRI to look at the ligaments. So I don't know if there's any thoughts about that. It's kind of an unusual injury.
Would you consider that if those also had a concomitant skull-based fracture? You think that's, would you consider that more of a almost like a skull-based fracture, or is that more of a like a craniocervical junction type injury?
It's a cranial cervical junction injury because the tectoral membrane is stripping off the dura here. And we looked back and none of these patients had clival fractures. You think a clival fracture would cause an epidural. The cases of clival fractures I've seen actually cause a subdural hematoma for whatever reason. A subdural hematoma can look very similar to this, but it's going to be on the other side of the tectoral membrane. Just anatomically, it's just the tectoral membrane distinguishes those two compartments. So it's actually a stripping injury of the TM, and it's associated with other ligament injuries, like in this patient. So it kind of is, it really is a craniocervical junction tear, a ligament tear that presents as this hematoma behind the clivus. So it's just based on the anatomy of the tectoral membrane. So this is the different kinds of tectoral membrane tears that we've noticed. So in kids, you get the stripping injury, the tectoral membrane strips off the clivus, you get accumulation of hematoma and blood products here, posterior to clivus, whereas, kids typically are more likely to strip ligaments and frankly rupture them or tear them. Adults are more likely to tear a ligament. So in adults, you typically get these tectoral membrane tears that are a gap in the ligament, and they can be high up near the basion, or they can be lower down near the dens. And in some patients, they actually can have a partial tear of the tectoral membrane. So in adults, you have tears in tectoral membrane where there's a gap, and there's a gap near the basion. This is a gap that's near the dens. And then you get kind of these weird injuries where tectoral membrane just kind of looks thinned out and stretched. And they're probably like kind of a partially torn tectoral membrane. But that's kind of the gamut of tectoral membrane tears that you see on MRI anyway.
I think that's really neat, Peter. Those are really neat pictures, and I don't really think I've paid attention to one, and I don't think I've actually seen it, thankfully, because I could only imagine if those become surgical, there would be a nightmare to fix. I mean, that's a tough area to get access to. So,
Yeah.
Ventral, craniocervical junction, I guess, obviously it's epidural. It's, that's a hard place. So thankfully those don't progress and don't expand.
Yeah. And these all get shipped out to our neighboring pediatric hospital. And all the cases I've seen, they're treated conservatively. And yeah, like you mentioned, we don't really see these expand since they're venous. All right, so your run-of-the-mill C1 burst fracture, Jefferson fracture, comminuted fracture through the lateral mass, the anterior arch, and the posterior arch. Maybe a little avulsion here in the medial tubercle as well, where the transverse lanal ligament inserts. And the reason I included this case is that when you look on the sagittal CT and you measure the ADI, it actually measures only 2 millimeters. So it's not strikingly widened, maybe a hair widened, but nothing crazy. And then when you look at the lateral mass offset and you measure this, the rule of Spence, it's 5 millimeters. And I think the cutoff was 6.9. And then you can see that, like Jonathan mentioned before, you can have these medial tubercle avulsion fractures here. The patient did end up getting a follow-up MRI, and they have a tear of their transversal lanal ligament associated with it. So even though the CT doesn't suggest the transversal lanal ligament is necessarily going to be torn, on MRI, there's a tear in the transversal lanal ligament. So, curious what you guys think about this, a comminuted C1 burst fracture with TAL disruption. And I included the AO type B, Dickman type 1 criteria here that I know some of you guys probably use. So I think it's unusual that the CT is kind of normal, but the transversal lanal ligament is torn here pretty clearly. So.
Yeah, I think if you go back to that CT, Matt, are you there? Matt Goodwin? I think if you go back to that CT, so that's that's a little bit different than the last case, right? That's just a little bit more obvious. And honestly, when you see that, and especially when you see the overhang of the lateral masses, even though it's technically less than 6.9 feet, it still looks abnormal, right? I mean, you can tell there's splaying there. So that ring is open. That ligament, you can infer without, just from the CAT scan that the ligaments are injured or torn. So I think this is kind of one that goes in the middle, right? The ADI is only about 2 millimeters, but it's not 1. There is, say, 5 millimeter of overhang, but not 7. I don't know. I don't know what. Let's see here. Dr. Burchak said he'd put him in a hard collar. I think I would agree with that. I would probably start with a collar, get an upright AP lateral before the patient kind of leaves the hospital. And when they sit up and they load their spine, if on the lateral that ADI increases, then I probably would consider a surgical intervention. But maybe a trial of a collar early on is not a bad idea. Matt, what do you think?
Yeah, I think I missed. This is an intact patient. Is that correct? Neurologically.
Yes.
This is a neurologically intact patient. Is that correct?
Yes.
Can you hear me?
Yeah. We can hear you, Matt. Peter said it's the patient's intact.
Oh, I'm sorry. For some reason, I'm missing that. Okay. Okay. If you can hear me, that's good. Okay. Yeah, I feel the same way. This would be, I'd be on the fence for all those reasons, and I would want to see. I'd probably, if they're intact, I'd probably have lean on the upright imaging as well, and I could go either way depending on the patient and how I felt about those. I agree 100%.
How much stock do you guys put in these, the AO spine versus the Gayweiler and Dickman classification? Are these classifications you use frequently or just as a guideline, or how do you incorporate these in your practice? Because honestly, these type C injuries, I've never seen a type C injury where you have this degree of translation of the ilanoaxial joint with C1 trauma. So to me, that case was more of this kind of type B injury. So I'm not sure if these offer any management guidelines or prognostic value or not.
Yeah, I think Peter, I think a lot of us definitely use different classification systems. The AO spine one tends to be popular. Really, I would say mostly for the subaxial cervical spine, but especially for when we're communicating with each other, or certainly for research purposes, I've seen the AO spine probably be a little bit more commonly used than others.
What are your thoughts on ORIF of C1? Meaning lateral mass screws in C1 and like a hard. Hold on 1 second. Hold on. Sorry, cleaning crew coming in. Or lateral mass screws in C1 and putting a bar horizontally to connect them together. Just internal instrumentation of C1.
Jonathan, are you talking about just basically reconstituting the ring of C1?
Yeah.
Yeah. I mean, I think that's really neat. I know a few people who do it, and they show the cases in which they reconstitute the C1 ring. I think it's neat. I've never done it before. I kind of have a very, how should I say this, a kind of a very dichotomous view on this, right? It's either highly unstable and I'm doing, say, a C1, C3, or an O to C3 or C4, or it's a collar. You know what I mean? If I need to just reconstitute the C1 ring, I think they may have been okay with a collar, but I don't know. I've seen those pictures and those images, and I think those are really technically great cases.
It's interesting if you do that, like, so why would the transverse alanal ligament matter? Like, I guess if you restore integrity and tensile force of the C1 ring, that's all you need to do to repair these kinds of injuries. Like, So why would the transverse anal ligament even matter for integrity? It's interesting. Like I think biomechanically, there's something that we're not fully aware of that makes sense, because if the treatment's either C1-2 fusion versus anterior osteosynthesis or C1 lateral mass screws, then why does the transverse anal ligament integrity even matter? Why image it, I guess, with MRI? I don't know.
Yeah, those are tough questions. I don't
I don't know.
I don't think many of us know either, Pete. And I think it's really interesting because I've seen more and more colleagues promote, say, C1, C2 fusions for complex C1 fractures, and for me, I think in my training early on, I guess the way I learned it is you have a really, say, unstable C1 fracture. It's actually not very common, but when you do have an unstable C1 fracture, I always felt that you have to bridge it, like go above and below. So we did a lot of OC fusions back in the day, but I think now we're realizing that even with comminuted fractures of C1 or burst fractures, I guess the ligaments that are compromised are the C1, C2 ligaments, like you were mentioning. But I think you're right. There really is a lot that we still don't know about the C1, C2 stability. That's the best guess I have.
Yeah, it's interesting. So this is the next case I have. So this is just, your run-of-the-mill avulsion fracture along the occipital condyle. And what's interesting about these is we had a slew of these cases, like 30, 35 of these cases come through here. And the majority of them get these follow-up cervical MRIs, and cervical MRIs are just always stone cold normal. The alar ligament, the mid-substance alar ligament, it's not a great image there, but it's intact. The rest of the cranial cervical junction ligaments are intact. There's not even any edema with these condylar fractures. And consider these kind of a low severity spectrum injury for cranial cervical dissociation. And this is just another case, again, bad image quality, but the MRI is always very underwhelming. So I think it's kind of cute to demonstrate if there's no other fractures or joint space widening or nothing else that's crazy on the CT scan. These are isolated little avulsion fractures. You probably don't even need to get an MRI. I don't know what you guys think in terms of treatment algorithms, but these typically are isolated, and the MRIs are typically negative for a lot of these condylar avulsions. I don't know if that's your experience.
Yeah, I guess I'll chime in again. Those condyle fractures, vast majority of the time, they're absolutely stable. We don't get MRIs. I actually sometimes don't even put patients in a collar for these, just because there's really, it's hard to stabilize that area anyway. Dr. Burchuk, again, made a good point about checking for cranial nerves. So especially with the avulsion fractures, you can get the hypoglossal nerve. So it's important during an examination to test the cranial nerves, especially cranial nerve 12. Not so much with the, I guess it's type 1 and type 2, not so much with the comminuted or the linear fracture, but with the avulsion fracture that perhaps tends to be a little bit more common. So, but for us, I don't know, JR, what you think, but for us, these are almost universally stable fractures, surgically speaking.
Yeah, I wouldn't normally get an MRI. I routinely will get an AP lateral X-ray on the patient. I always want to, for trauma case, I always get an AP lateral X-ray. But I wouldn't routinely get an MRI for this. It's usually stable.
I think for neuroradiologists, they see that and they want to suggest there's all these ligament tears, and it never is the case. It's scary, you're like, oh gosh, there's a avulsion of a ligament. But yeah, I think it's kind of overly dramatized, at least for the radiologists. When they see that, they love to recommend an MRI. It's generally not necessary. So this was a case 6, another motor vehicle accident. And, I included this case because, like we saw, sometimes the bone windows on a CT scan only tell you half the story. And it's important to flip on the soft tissue windows and always get a good overview of the soft tissue. So this is abnormal here, this hyperdensity within the supradental space. That shouldn't be there in a younger patient. Obviously, in an older patient, they can have rheumatoid or osteoarthritis. But in a younger patient, that shouldn't be there. And then, obviously this prevertebral effusion shouldn't be there either. So we've had a bunch of these cases in which, the patient then gets a follow-up MRI and you have, major cranial cervical junction tears again, the tectoral membrane's torn. transverse atlantal ligaments torn. You have this prevertebral effusion, anterior complex is torn. And really the best clue of it on the CT was the fact that there's a hematoma in the supradental space. So this was a severe spectrum injury presented with the supradental space sign. And just for comparison's sake, this is what the supradental space, this little space superior to the dens should look like on CT and MRI. So it should have low attenuation fat within it, and then it should be bright on your T1 and T2 weighted sequence. And then, of course, here's the apical ligament that's going through the middle of it. And it has this venous plexus within it. And sometimes you get bright signal on a stir sequence because when you suppress out the fat on a stir sequence, all the veins stay bright, and there's a little venous plexus up here. So you can get this bright signal. But I just include that case so you could see that, use soft tissue windows too on CT. I have another case to show you that was a similar kind of rule. I tell all my residents that as well. You'll definitely pick up some really important things if you do that. All right, so this is another case. So this case has, again, there's a little bit of widening here of the Bayesian-Dens interval. If you measure 11 or 12, then yeah, you have another kind of supradental hematoma going on here. There's kind of brighter density here. And then in addition to this time, now you can see epidural hematomas. You have a dorsal epidural hematoma at C12, and then you have a ventral hematoma or effusion, I guess. I mean, probably a mixture of blood and fluid here. And then when you look on the axial, you can see how the dorsal thecal sac is displaced anteriorly. And it just again shows that, when you look at the MRI, this patient has all these cervical ligament tears. And this is a kind of finding that we've noticed in a bunch of patients in which the posterior atlanto-occipital membrane, if you remember, it forms a myoligamentous dura bridge. So it attaches to the dura at C12, and you can strip it off. So this is the membrane that's been stripped off the dura, and it forms this little dorsal epidural effusion here. And sometimes you can see it on CT, and then it's much clearer here on MRI, and it's indicative that the posterior membrane complex has been compromised or torn. And it's generally associated with other ligament tears as well. So if you see that effusion or hematoma C12, you can kind of infer that the posterior membrane complex is compromised. So again, that's just a dorsal epidural hematoma and a supradental space sign on the CT. So again, sometimes these severe injuries, the soft tissue windows really help a lot. And we did a study and we looked at the different MRI patterns of posterior complex injury and what it can look like. And it goes from kind of a low-grade injury where you just have increased fluid or edema on the stir within the complex, and then it gets a little bit more significant in which the rectus, posterior, major, and minor muscles get edema, and there's soft tissue edema that extends more posteriorly, and then you can actually become stripped off the dorsal thecal sac as it becomes more severe, and then the most severe is actually fully disrupted and completely gone. And these two injuries are associated with really significant high-grade injuries, whereas these two are more commonly going to be isolated tears. And you can have edema within this little compartment in the setting of a C12 fracture. There was a study that came out that demonstrated that this can actually be a finding of an occult C12 fracture. If you don't have a CT to look at, it's kind of a secondary finding. So those are kind of the different injury patterns. But yeah, just to kind of demonstrate the importance of the soft tissue windows on CT exam. This is the last case I have. So this was a 5-year-old motor vehicle accident. Very subtle case here, a little bit of asymmetric widening of the central C2 synchondrosis in a 5-year-old. It should be fairly congruent and similar distance as you go all the way across. And then if you look at the dens, is ever so slightly ventrally tilted, the dens in relation to the C2 body. And there's a very subtle widening of the posterior synchondrosis of the dens. And because of those findings, the patient actually got a follow-up MRI, and it demonstrates, I guess you could call this a Salter-Harris 1 type injury of the central C2 synchondrosis, but there's a little bit of edema within the synchondrosis, and then there's a posterior membrane complex injury, or maybe some referred edema from this injury posteriorly. So just as a reminder, I tell my residents that, Syncyondroses are difficult if you're not used to looking at peds, and we don't look at a whole lot of peds here. But the growth plate should be nice and smooth and symmetric as you go all the way across in kids. So it's just kind of an important reminder. So that's kind of it for my 8 cases. I just want to, close it up by saying, there's a spectrum of varying osteoligamentous injuries that occur. They may or may not predispose to instability. It's still kind of, there's still a lot we don't know about the craniocervical junction, which is why I kind of find it fascinating. The cervical CT findings can be flagrant, AOD, or they can be very subtle. Sometimes you need to really pay attention to all the joint spaces, the soft tissues, and that, cervical MRI is probably underutilized to some degree, at least from a neuroradiology perspective, but maybe not. I mean, this still needs to be studied, the role, I think, of cervical MRI in the setting of craniocervical trauma. I don't think we really feel comfortable how that fits into the algorithm, how it fits in the algorithm for you guys treating these patients. So, but anyway, I don't know if there's any questions about that, but that's all I got on my end. So go Gators.
Peter, that was awesome. Just a question for you. For these patients with upper cervical injuries, what are the, I know that the guidelines are hard to come by, but just generally protocols in terms of CTA for those patients?
Yeah, that's a great question. I don't know. I mean, I feel like every institution I've been to does it differently. There's a lot of CTAs that we do. Basically, if there's any fracture that goes anywhere near a transverse process, foramen transversarium, any that goes through the skull base, even significant facial fractures, or any of these cases, I bet you the majority of the cases I showed you, they all probably got CTAs. I'd be shocked if none of them got CTAs. The CTAs are generally negative, but you just don't know. And sometimes it's the injuries that you don't expect present with a vascular injury, and the ones you're like, oh, there's going to be vascular injury here, and they're negative. So I think it's very hard to predict. I would always err on the side of caution, to be honest with you. I feel like it's hard to predict which ones are going to present with a vascular injury and which ones aren't. So
Generally low downside, right?
Yeah, low downside.
Did you, Ali and Matt, thoughts on CTAs? It's actually a really good question, because sometimes I feel like we maybe do it a little bit too much. It's like literally any fracture at C2. It could be like a little fracture of the body of C2, or like a dense C2 dense like tip odontoid fracture. Like the ER and typically gets CTAs for any one of those fractures. So I'm just wondering your thoughts. Is it protocolized at your institutions? Do you routinely get them?
Yeah, so we're probably the same way that they're typically done, and it's already been ordered. If there's anything near a transverse foramen, if there's anything suggestive at all, oftentimes it's like somebody was saying, they're either negative or maybe an intimal tear or something. I guess I wonder if you guys can tell me, right? Because usually that's not managed by the orthopods when they have some sort of intimal thing and go on aspirin for a while. I don't know how common that is or who's managing that. But yeah, Peter, before I know we're gonna get cut off, so Peter, thanks, but that was awesome, and that whole talk makes me feel a little bit better about the conversations we have here with these tweeners, where we're kind of going, well, this looks torn, and this is, let's get some uprights, and so really, really great talk. Appreciate you giving that.
I appreciate that. Thank you very much. Thank you for inviting me. It was fantastic.
All right. So thank you very much, Peter. Thank you very much, everybody, for joining us. Some great conversation, some great discussion, and some great spine presentations. So I hope to see you next week, and everybody enjoy the rest of your week and weekend. Take care.